go ahead and get started with this. Does anybody have any questions, if you've even looked at it, the morphology or the concepts surrounding that lecture?
I don't have a question about that, but I have a question about something that Vanetta said earlier, documentation-wise. If you're gonna send a patient home with a script and tell them to like fill it later, do you put that in your documentation saying that?
Yes, so great question. Two components to that. Yes, like I'll say, especially like in my Good Shepherd, I'll say paper script provided to patient, da 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 da. That's the other day with a patient that I had seen. But even when you give a paper script to somebody, you have to enter it in your EMR. So like if you gave them a paper script for amoxicillin, see you later, get out of here, there is a thing in EMR where you type in a script. It's not so much like I'm sending this through EMR to your pharmacy, it's called a record button, like I'm just recording this. 3 ways you put meds in. 1, historical meds, so the nurse will put down, she's been taking lisinopril for 20 years, so now it's in her chart. Then I'm giving you a new prescription today for amoxicillin, here it is in your chart, and then I provide the patient with a paper script, but I still have to electronically put it in there, and it goes in there. And the reason it does that, because just in case you forgot to write for a paper prescription provided, you wouldn't miss it. Like, it'll be in their chart, so someone will know this person took amoxicillin a week ago. Does that answer, did I answer that?
So even though you're not sure that you want them to fill the script?
Oh, I would never give someone a script if I didn't mean for them to fill it.
Okay. He was just saying like, let me give them a preventative script in case my whatever comes back, and then I say, oh yes, I'm gonna put you on treatment instead of having them come back.
Okay, so like, let's say I had a kiddo, or let's say I had an adult that was like on the cusp of maybe developing a sinus infection, and I thought, okay, yeah, okay, sure. So, yes, I'll give them a paper script, and I'll say, there's some amoxicillin. If you start to develop fever, facial pain, worsening of symptoms that are indicative of a sinus infection, you absolutely go get this filled. And you will type empiric treatment provided to patient, gave them instructions, patient voice understanding.
So Dr. Vanetta was saying to supply the prescription and say, once I get my lab results back, I'll call you, tell you, fill it up or don't fill it. Get that prescription or not. How do we document that? So do we just say like, supply prescription, we'll call patients to let them know if they should get it filled? Because
and this is provider specific, and I'm not saying there's anything wrong with what that way, but I would not do that. That's just me though as a provider, I don't do that. I don't ever give someone a script that I can't trust them with later on. I'm even freaky about antibiotics actually. It takes me a lot to be able to even give them a paper script and say, if you don't get better in 48 hours, here's a script. I'm just really weird with giving people prescriptions, but that's probably because I'm a new provider. I understand where he's going at, and there's nothing wrong with that. You can totally, if you feel comfortable, it's all about trusting your patient. If you trust them and you know they have good follow-up, and it's not once they leave, like a patient at Good Shepherd the other day, I can't get a hold of the woman to save my life. And I'm like, oh my God, is she dead? Did she take it? What is going on with this lady? So if you trust your patient, you have good communication with them, and you call them and say, look, their triglycerides are stinking 600. That simvastatin prescription I gave you, you need to go fill that. Most prescriptions though, and Dr. Vanetta's not an EMR user, I don't think he's ever used it. He'll tell you, I don't think he's ever actually been on EMR. I don't think he's ever used an electronic medical record. Most prescriptions go electronically. You can do paper, there's nothing wrong with that. But most, you just get on there, or you send a flag to your nurse and say, hey, call Joe Blow with their labs. After that, send this script for me. But you can do that. That's cool. That's totally cool. Yes, ma'am.
But also it was for iron, and iron you can buy over the counter too. So he's probably just giving her a little bit of a higher strength, so it wasn't anything that was risky at all.
Right.
So that was, I think that was also part of his point, like, it's not,
Sure.
it's not like a risky.
But what if let's say it was quote unquote risky, the simvastatin, lisinopril, you could totally do that if you are comfortable doing that.
But with our, like now EMR, you'll just, instead of saying go fill it up, you'll call her and say, I just called you in a prescription at Walgreens.
That's exactly right. You just say, I just sent it through your EMR, or I sent a flag to my nurse, give it a couple of hours, it's going to be there waiting for you. I usually, and again, it just goes back if your patient understands you at all, usually when I get labs back on a patient, and again, I'll just go back to Good Shepherd, especially if there's a language barrier, I tend to call patients in and face-to-face with them to give them their lab results. Because most people are like, what are you talking about? And it's just easier, and then you can also do medication, like, here is simvastatin. If you start to develop any kind of muscle aches or this, because that's a risk factor, that's a side effect of that drug, or belly pain, because it makes your liver enzymes increase, you need to, I don't know, I just do face-to-face a lot, but those are excellent questions. Any other questions along those lines? Those are good things. Good question. Okay, so the morphology, anything about that? Anything about that? There's no way that needs to be a complete lecture. That is something that can just be given to you, and you need to review it when you're getting those ClinMed lectures. And then also, I'm assuming your med term is also going to be covering a lot of those topics, and that's where you'll be tested over. Correct? Again, I don't look at your med term stuff. I apologize. Is it somewhat the same? Okay. Someone's right shaking their head, yes. Okay. If there's any other questions, just jump out there. So, bacterial skin infections, my topic that I covered today. Again, this is obviously clinical medicine. This is not phys die, so the questions I write, if the course director chooses to use them, will be tagged clinical medicine. So again, I try to be really transparent with this stuff. I think it's important. This is the medical condition list that I'm going to be covering today. As you can see, several of those topics are both on your NCCPA blueprints, which is your boards. Those are the things they expect you to know for your boards. And then also, I'll start, I know we're kind of getting towards the end with you guys, I'll start telling you actually what's exactly on your end of rotation exam list. This would be for family medicine, if you were taking your family medicine end of rotation exam. Barnacle and carbuncle and folliculitis. I believe Brooks added folliculitis to your medical condition list for this module. But actually, folliculitis, barnacle, carbuncle are not on the NCCPA blueprints list. Like if you go to ncca.org or whatever it is, you can look at it yourself. It's not on there. She added it because it really probably does need to be on there. I mean, folliculitis, come on, that is huge. It's extremely common. So we're going to cover it today. Any questions about that? Lecture objectives, you know these by now. In regard to etiology, all I really want you to know, if I write a question, it will be what bug is responsible for this. That's all I would ask. A patient has yada, 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 yada. You think it's erysipelas. Question is, what is the most common bug? That's like usually my go-to. And that's what the question will be on your boards. And it's important because you need to know what medication you give them for what bug. Anytime you're in derm and you have no idea, it's either Staph aureus or strep group B, or group beta hemolytic group strep. That's what the two answers always are. Usually it's Staph aureus. That's what's on our skin. Anyway, there's that. Just a nice little picture. I like this picture because a lot of times when you start to think about bacterial skin infections, and again, it's why anatomy is somewhat important because you need to know what layer is being somewhat affected because it will present differently in accordance with what layer is being affected. So epidermis versus dermis versus sub-Q fat, and then also the hair follicle because the first three conditions where they cover are mainly focusing on the hair follicle itself and the surrounding tissue, but mainly the hair follicle. Not going to go into this slide a lot. The main take-home point here is the majority of the things that I'm speaking to you about today are secondary to, we know the skin's a protective barrier, right? That's what it provides for us. These infections, they don't just spontaneously erupt. Something has to break that protective barrier to get that bug in there. And that can happen a lot of different ways. Usually it's trauma, some type of wound, they stubbed their toe, cut their foot, whatever. But it can also, as you'll see with our first three topics, be introduced via the follicle or the pore. I put this slide in here because it's really important for you to understand this terminology, especially in regard, because this is how you really do it in practice. And you'll hear this when you go out in your rotation. So when a preceptor says to you, do you think this is a complicated or an uncomplicated infection? You won't be like, I don't know what you're talking about. Here you go. There are certain ways you determine if a skin infection is complicated versus uncomplicated. And here's somewhat the criteria that you need to understand. And it will determine your course of action or what you do next. But you can read this. I will not write a test question from this slide. I just want you to know that this is very real, and this is how you need to think about skin infections when you are out on your rotation, specifically inpatient. Because 99.9% of the time when you have skin infections in your office, you're going to be like, do I get antibiotic? Do I don't? I'm on the fence. What do I do? What I do? You're going to do it. You'll do it. If you're a good provider, you'll do it. It's a hard road to road because you're just like, I don't know. Do I give them something for this? This will hopefully kind of guide you. Yep, I need to go ahead and give them that oral antibiotic. It's hard. It is hard. Okay, folliculitis. Extremely common. Probably half the people in this room have had some form of folliculitis in your life. If you shave your legs, shave your face, bikini line, armpit, any of those areas, you've probably gotten folliculitis. It is inflammation, because that's what itis technically means on the end of any word. That's what you're supposed to call it. That's okay. It's inflammation and infection to a certain degree. But there are certain types, I don't want to confuse you, but there are certain types of folliculitis that it's not so much an infectious process, it's just an inflammatory process. But for the most part, it is inflammation that's caused by an infectious process going on. It involves the hair follicle. And I know I'm sounding like, okay, you can get this here. But when we get to furnicle and carbuncle, you're going to be like, well, I don't get it. It's basically the same thing. And it somewhat is. It's a continuum. When I think of folliculitis, I think of just the surrounding area of that follicle. Furnicle, we'll get into that in a minute on furnicle, is the follicle and the surrounding tissue around it. So just kind of keep that in your brain. Because even last night when I was reviewing my lecture from last year, I was like, God, that is basically the same stinking thing. I'll show you why they're not. So inflammation, infection of the hair follicle. What's highlighted in red would be your test question. If it's ever in red, make sure you memorize that. I'm not saying I'll write a question on it, but if there's going to be a question, it'll be over what's in red. So it is caused by staph. That's like the #1 bug. It can be Pseudomonas. That is your hot tub folliculitis. I know you've probably heard of hot tub folliculitis. Have you ever heard of that, or even had it yourself, actually? It's really common. People get in a hot tub, and they get infected, and they get a bad folliculitis from it. Pseudomonas is that bug, which it kind of grosses you out. Ooh. I love you good hot tub. Okay. This is just kind of breaking down how it works. So you have, again, this doesn't just miraculously appear, this folliculitis. Something has to happen to that hair follicle. I always think of men, like face, because you see men who get it on their neck, they'll have that really bright red bumpy look. This is what I think of. I think of shaving. There's something that damages the follicle. That's what bullet point #1 they're saying. The damage is some type of irritant. That irritant can be many, many different things. I've listed out some of the more common things for you. Clothing, really tight clothing can cause it. So clothing that rubs on your skin back and forth. I've seen this in people who like to ride bicycles. They'll wear like bicycle shorts and they'll ride long places and they'll just have a horrible folliculitis on their butt, cheeks, and inner thighs because of that bike shorts rubbing. Trauma, shaving. Huge shaving causes it all the time. Or the follicle can become blocked by sweat, oil, makeup. This is different than acne. Don't get it confused. This is not acne. It can look the same though, but this is not acne. Sweat, oil, makeup clogs up that follicle. You get this inflammatory response, all those awesome things that start to go into that cascade that we know for inflammatory. We got your WBCs, you got your neutrophils, or neutrophils are WBCs, you got macrophages, they're all coming to that area, and that is when you start to get the signs that we see, the redness, the swelling, the pain. That's just a little fact there. Hot tub folliculitis is because the water's not treated appropriately. Basically chlorine is what, that's why we put chlorine in pools and hot tubs. The last bullet point is important in that a lot of times what males will get, or even females for that matter, especially if they have very dark, thick, coarse hair, especially in the bikini area or in their armpits, they have stiff hairs that will grow into the skin in an inappropriate manner. That can cause like a chronic folliculitis, and that is the pseudofolliculitis barbae. That's basically what you see when the men have that really, my husband has it, he can't even shave. He went to try to do the hair removal right here, laser, just so he wouldn't shave, because if he shaves, he has this horrible folliculitis on his neck. Has anybody ever seen a man with that or experienced yourself? I don't know. It's really horrible looking and painful. So the pseudofolliculitis, it's good to know that though. So if a man comes to you and they're like, man, every time I shave, I get him. It's not so much an infectious process, and you need to be mindful of that. That is basically razor burn because of their hair growth. This is just a great, I love, you know me, I love these pictures. That's how I get things memorized in my head. I will not get into superficial versus deep folliculitis. I just want you to know folliculitis, but there is a difference. There is. And again, it's just basically what it says. It's the area that's being affected. Is it very, very superficial, or is it entailing the entire follicle? And that's basically what those pictures are showing you there. Again, I've already said some of the common locations. Face is the biggest one I think of. But you can technically get it anywhere that you have trauma or rubbing or damage to the follicle. Bless you.
Thank you.
Chest, back, arms, legs, buttocks is a big one. I had a gentleman that he did the Chesapeake rowing team thing, whatever, and he came into me and had a horrible folliculitis on his butt cheeks. And I tried to treat him with everything under the sun, and it turned out his was secondary to a water parasite. So it wasn't, because he's in the water all the time rowing. God knows what's in that water. And I couldn't just throw at him my good old Keflex, my good old bathroom. I had to amp it up a little bit. But he had it from that friction of going back and forth when he was rowing. Signs and symptoms of it. So how is this going to present to you in your clinic? Usually you will see a little pustule. So you'll see a tiny little pustule, so a little blister, a little pimple looking thing, but not a pimple. I hate to use that word, but that's the best way to get you to think about what it looks like. There will be a hair in the center of it. You don't ever have folliculitis on skin that doesn't have a hair, because that's what folliculitis is. It has to involve the hair follicle. And this is very true because Rob can do it. You can actually take a pair, if you have a little pustule, you can take a pair of tweezers and grab that hair and it will just come out as easy as can be, because basically all that inflammation has loosened up the follicle and you can just pull it right out. It's not like if you were to pluck a hair and it hurts. It's very weird, but you can do it. There is, of course, itching, pain, burning. The skin will become red and irritated. I have a great picture here for you in a minute. It can lead to scarring. And if you've ever seen a gentleman who has had horrible folliculitis, they will have scarring from it. Because obviously anytime you have damage to your skin, if it's chronic, you're going to get scarring. I want you to be mindful also, especially in derm, because again, our skin is our outer, that's the first thing people sometimes see of us. It's very debilitating, embarrassing, and emotionally stressful for individuals that have to deal with anything that is not perfect about our skin. We often love and should give scripts for medicine, but there are other things we need to treat as well. And you have to deal with the emotional aspect of a lot of this stuff, especially acne. Acne is the biggest one I think about. It can be very, very, very embarrassing for a patient. Diagnosis, I spoke to you guys about this before. Anytime you see based on clinical presentation, that means there's really nothing you do. You don't go do some fancy workup, you don't order a lot of tests. You just walk in, I hear your story, and I know that's what's going on with you. So nothing to do here. You just visually see them and that's your diagnosis. Treatment plan, there's a lot of different ways to avoid folliculitis or help with folliculitis. And you don't need to just start with meds. You need to first think about, like, let's look at how your skincare regimen is. Or what are you doing that's causing this that we can eventually or hopefully kind of decrease or take out. So address that. If it's tight clothing, stop that. If it's some type of repetitive friction that they're doing, whether it's exercising or whatever, try to avoid that. Address that stuff first. Don't just jump right to meds, as we often do. So avoid shaving. They have to change their razor often. I am guilty of it. I think I have a razor from 6 years ago that I still use. I use a razor forever. It's disgusting. Change the razor. I actually tell people, it depends on where they're shaving and what they're shaving with it, but I tell people if they have bad folliculitis, I tell them to change it every 2 weeks. But razors are extremely expensive if you go, if you go buy them. So you have to be somewhat realistic. But you have to tell them, if you're going to freaking use a razor that has rust on it, you're probably going to get folliculitis from this. I mean, you just have, it's... if there are some pustules that are there, especially like in areas, you can use warm compresses on that area, wherever that may be. You can have them put a warm compress on it to help just relieve some of the inflammation. It helps with pain. And in some instances, it will open up those little pustules. Because you don't want to be doing this bit, you don't want people squeezing on them, which we all do it. That warm compress will help unroof those pustules. I tell people realistically, you always hear about warm compresses, you're like, when do people really have time to go warm compress? I tell people, if you can do it twice a day, that's awesome. Most people can't. I say do it at night when you're watching TV for 10 to 15 minutes. Get a towel, stick it in the microwave, watch it closely because it can catch on fire. Just warm it up in 5 seconds. It can do it. Warm it up in 5-second increments, or get one of those, because those people don't have those little fancy bag thingies with stuff in the middle that obtains heat. You can use a, don't get fancy, you can use a towel. Just warm it up in the microwave and stick it on there, wherever it may be. 15 minutes, 10, 15 minutes, once a night. That's your instructions to them. Antibacterial soap is also excellent for this. Like Dial is the main one that I tell people to get, you know, D-I-A-L, it's over the counter, you go to Walmart. There is a Dial antibacterial soap, and it says it on there. It is excellent, excellent for cellulitises, folliculitises, any kind of bacterial skin infection. It's excellent. And I'll tell them, you need to wash wherever it's at with that soap. It will help decrease this becoming more infected. I've already basically said number 2. The last 2 bullet points, this is really important. Women hate this though, but I've actually given this education to patients. If it is a severe enough or a chronic folliculitis and you really feel like it's secondary shaving, they need to stop for at least 3 months to basically let, because what it is every time you shave, you kind of cut that hair in a funky way. It's like an ingrown toenail almost. And it grows back in an odd way and just causes this inflammation when it starts to pop through. So you have to tell them to give 3 months to let the hair fully grow out healthy. Most people will not do this. I probably would. They can start shaving, but this is a really cool trick and it actually works. You tell them to shave not against the grain, but the opposite direction. So if they're just like, I am not gonna not shave, say, gotcha, go the other direction. It's not gonna give you the smooth shave that we want, but it'll cut the hair, but you will not have any growth like you're having. Does that make sense? It's a really cool trick to try. So if you want to initiate medications, which I will tell you, the majority of the folliculitis I see, I give them a medication. I just do. Because usually they've been dealing with it for several weeks, months, years, they're sick of it, and they're embarrassed, and I'm like, I feel you, let's start something. And you can do that, that's okay. Clindamycin is excellent. It comes in a 1% lotion or gel, and there's the stick for it. You can apply it topically twice a day for 7 to 10 days. I usually do 7 days. Benzoyl peroxide is another one. There's different formulations. 5% wash is the one I tell folks to go get. Keflex is my actual go-to. That is my go-to if they do not have an allergy to it. And it's just an uncomplicated folliculitis. I love me some Keflex. But there's other meds there that you can see. I hate saying that word, dicloxacillin. I always feel like I'm going to say it wrong. That's an excellent medicine as well. It's really good. The only problem with the Keflex is people will not take a pill 4 times a day. That's a lot. But I usually actually write it for TID. I do it for 3 times. But it's a great drug for folliculitis. If you feel, and that's basically what the last, that if these measures do not result in cure, blah, 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 that's basically if you think they have a resistance to it. They have like a MRSA or SSA, they have something along those lines, you're going to need to go a little bit further with this individual and choose an antibiotic treatment that's going to help with that. You can culture anything in any liquid that comes out of the human body. If you wanted to see if you had a resistance, all you would do is take like a needle and pop one and just get one of your culture swabs and swab it and send it off and let them plate it out and grow it for you. It's going to grow Staph aureus because you just rubbed it on their skin. But it will tell you if it is, they'll do a culture in sensitivity, they'll put it towards all the big antibiotics you use, and it will come back and either tell you if it's susceptible or resistant. And you can use your bacteriogram to help you with your medication or change your medication. It's an excellent. So don't ever be afraid to pop something and get some juice out of it and send it off. You can totally do it. Here's just a picture. I did. If you go down into my notes section, I actually wrote out for you your options for MRSA if you've got back a resistant strain. Do you see that down there? I know I put a lot on my slides, so I try to. Clindamycin is excellent for MRSA or a resistant or susceptible, resistant strain. The only thing about clindamycin is, what do you worry about with clindamycin?
Diarrhea.
But diarrhea is secondary to what? Does it happen? Sure. I actually had a patient that he got it because I gave him clindamycin. But it's a risk, and you have to take it if you have a patient that is resistant. I will tell you, ERs give that stuff to kids like candy. That is like their go-to for pediatric patients. So I used to be scared of clindamycin. Like I came out of school and I was like, oh, I ever know C. diff, I'm not touching it. But I finally was like, why am I scared of this antibiotic? And I started using it, and you will get excellent results with clindamycin. So don't be scared. Don't be scared. Don't be scared. Do it. You just got to do good follow-up with your patient about the diarrhea. Bactrim, you'll see that listed on there. It is still we still love us some Bactrim. A lot of resistance though coming up from Bactrim, as you know, because it's been around for a gazillion years and we use it for everything. It's still good though. It's still a really good go-to drug. What's the thing you have to worry about with Bactrim? Oh, you may, hopefully you'll get it this module. Stephen-Johnson syndrome. It's a very, not common, I don't mean to say that. It is something that can happen from back, especially in your kiddos. Stephen-Johnson, it can be life-threatening if it turns into a toxic necrolysis, but hopefully you'll get that lecture. Just be mindful, Bactrim can cause some weird reactions in people, so you have to be mindful of that. So these are some pictures of folliculitis. Again, it kind of looks like acne, right? You're like, oh, that looks like acne. You'll know the difference when you see acne versus folliculitis. Again, with your folliculitis, there has to be a hair follicle in the middle of it. And usually with acne, you'll have, honestly, kind of like that gentleman's face. Folliculitis is usually in a more bar-type confluent pattern. And you don't get acne in the armpits, the groin, the leg. I mean, you'll know it when you see it. But it is, you know, I want you to start thinking about morphology in my lecture. And I actually have a couple of slides. Like, so if you were to look at that picture right now, you should be testing yourself. Like, how would I describe that, or how would I write that in a note? Diffuse, various sizes, erythematous papules located on the upper forearm, neck, some pustules noted. No increased warmth. Patient denies pain with touch. Okay, so that was folliculitis. Any questions over that? Pretty basic stuff. Folliculitis I think of as very superficial, not so bad. Do some wash, stop the tight clothing, we're going. Barnacle and carbuncle, I think, is a little bit more serious condition. It can be a little bit more aggressive, a little bit more painful. They can get an abscess formation from these things. So if you had a continuum of folliculitis, more superficial, barnacles next, and then carbuncles next in regard to getting deeper, involving more surrounding area, not just the follicle. Okay, so everybody has probably heard somebody in your family or somebody you know say, I've got a boil. Boil, you've heard that. That's like an old, this is essentially what they're talking about. All a boil means, which essentially is what a furnicle and carbuncle is a follicle has become infected. It's pretty severe. It's involving surrounding tissue. And there's a potential for an abscess to form in it. You've seen boils. They're red. I have a little pussy thing on them. You need to drain them. You got to pop and drain them. The difference you need to know between furnicle and carbuncle is, I hate saying these words. Furnicle involves one hair follicle, just one, as where a carbuncle is multiple hair follicles are involved. I don't know how many, 3, 4, 5, 10, 20, I don't know. One versus more than one. That is your biggie there. You need to know that. So you have this inflammatory response. An infectious process starts to ensue, which causes your inflammatory response. Sorry, I said this other word. It involves one hair follicle. It starts to spread out to the surrounding tissue. So now you have your furnicle, no longer folliculized because it's moved out further. Then it starts to move further into that second hair follicle and that third hair follicle. It coalesces. You have several inflamed follicles. Now you have a big old inflammatory mass, and that is essentially what a carbuncle is. That's pretty straightforward. We'll get to deeper skin abscesses later in this lecture, but these are more superficial. These are not, they can, if the person has the right conditions, it can develop into a big old mass. But these are very superficial. You could probably take an 18 gauge and pop them and get all the junk out. This is not to where we're gonna have to do an incision and drainage just yet. We'll get to that in a bit. Staph aureus, memorize that. I told you everything's staph. Common locations, it can occur anywhere, but it's usually, obviously if it's involving the follicle, it's gotta be in skin or hair-bearing areas. Face, neck, axilla, breast, buttocks, thigh. Those are the main areas that your frontals can be. Carbuncles tend to be in areas of thicker skin. That is true. The biggest one that I've ever seen it is the nape of, right here, the nape of the neck. That is where you'll see carbuncles a lot. Especially in African American people. And that is a thicker skin, if you think about it. There are risk factors for this. There's risk factors for any skin infection. Anytime you have something that breaks down your defense system, you're going to be more prone to getting skin infections. So anything immunocompromised, diabetic, HIV, someone on chemo, someone on radiation, your age extremes, little bitty, older, you're going to get tons of kids that come in with, not this, well, yeah, actually this, that comes in with boils and abscesses. Oh my gosh, you're going to get it all the time in your family medicine practice. So how do these present? Clinical presentation. So it is deeper. It's a subcutaneous inflamed erythematous. I try to write out the morphology words for you. Erythematous nodule. Because again, papule's kind of small, right? I think of a papule as this little thing. Nodule's getting a little bit bigger. A nodule, as you put your fingers on, you're like, wow, that's a little bit bigger. Because again, this is growth. This is involving more area. It can be fluctuant, it can be indurated. Indurated, like I told you the other day, and I have this little thing I'm going to do for your class, not today. Where indurated, if you feel of it, it feels like this table. Fluctuant feels like a water balloon. Fluctuant means I'm going to have to cut you open and get all that pus out. Indurated just means there's so much inflammation in that tissue, it's nasty. And it's probably going to form some pus, but right now it's just hard and red and inflamed and hot. And I'm not going to put a needle, blade in it yet. Of course, the overlying skin will be erythematous. You may have increased warmth depending on the size of the inflammatory response. If it is a carbuncle, you can have areas with multiple sinus tracts, and you'll see the pus draining out of them. I have a picture here in a minute. There's lots of pictures in this lecture. Because again, if it's involving multiple hair follicles and you have that skin surface, you're going to see pus coming out of each one of those hair follicles. If that skin surface has multiple hair follicles involved, you'll start to have some tissue loss eventually. And that's where you get like an ulceration type appearance. And that's what that means right there. Basically, the top of that skin is going to be gone for the area that's involved. There could be drainage. We like to use the word purulent. You can say serous, serosanguous. There are different words to describe exudate. If it's big enough and they are immunocompromised, you can have systemic symptoms. Most of the time you are not. And you know what we mean by systemic, meaning it's a systemic response. Your body is wholeheartedly trying to fight against this. It's kicking it up a notch. So all those inflammatory markers are going to start to release that cascade. You're going to have fever, chills, nausea. It's your body's way of saying, I'm trying to fight this off for you. You, again, usually will not have those symptoms, but be mindful of it. Carbuncles, of course, because they're bigger, they involve more surface area, it will take a long time for them to heal. They're the ones that are more likely to scar as well. So good wound care is important because they will get some major scarring, as any skin infection can have. So this is probably a fairly good representation of a furnicle versus a carbuncle. You can see how the carbuncle has multiple sinus tracts. Do you understand that? I mean, it's, yes. Oops, did I do that? Sorry. The left lower one is like a classic carbuncle. You'll see that on the nape of someone or the back of someone's neck. It's a common look right there. Okay, here we go. Andrew, how would you describe the skin finding? If you were trying to explain it to me as you're attending.
It's one question.
Pretend, you can pretend too, like you're sitting there looking at the kid's arm, like you're touching it.
Oh, pain, palpation.
Okay, where's it located?
Oh, on the volar aspect of the forearm.
Very good, yeah, awesome, yeah.
It's fluctuant.
It's probably, yep, you're probably right without pretend touching it. And I know you don't have a ruler, but you would want to, measure the erythematous area. Erythematous area is probably about 3 centimeters by 2 centimeters. Fluctuant center is 1 centimeter by 1 centimeter, something like that. I always also say not unroofed. Basically, it's still intact. No red streaking present. This is how you need to test yourself. I know internally you're going, yeah, you can do it. Good job, Andrew. That's a pretty intense carbuncle. And again, I know some of these pictures are like, that looks like one, that looks like a furnicle. You'll know the difference. It's just bigger. Yes, ma'am.
So how would you differentiate that, just looking at it, from like an ulcer or something?
Well, essentially, it kind of is an ulcer, because what is an ulcer?
All about skull.
It's skin loss. It's skin loss secondary to something, either trauma, infection, whatever. It is essentially, that's what I was saying earlier. If you're doing if you're thinking carbuncle, and you have a lot of skin surface that's involved, and you have stuff popping and draining and whatnot, eventually that skin's gonna kind of slough off and you will have an ulceration. But that's a great question. It is technically ulcerated.
Is this also technically like staph? You know, like when you get staph on yourself, or like wrestlers?
Well, we all have staph.
Well, then, like,
Everybody
the
has staph aureus on their
infection of
skin.
it. Is that technically what it is, since it's actually the bug staph usually?
That, I'm assuming that's probably what is causing the infection. Does that answer your question? It doesn't have to
I
be
just-
staph, but everybody has staph on their skin. Everybody does it. Anytime you cut your skin and open it up, some bug can get there and cause a nasty infection. 9 times out of 10 it's staph, because obviously there's 1,000 of those people in the room versus the 2 Pseudomonas standing over in the corner. So the odds of them getting in that wound are higher, but it can be other bugs.
But when people say, I have staph, is it also kind of like a furuncle or
They
a
actually,
carbuncle?
they say, people say I have
Like I
staph
have a staph
infections.
infection. Yeah.
They really don't know what they're saying. You can educate them. You say, we all get staph infections. Because staph is, but that's a great question, because they will. They'll say, I get staph infection all the time. I'll say, yeah, most people do. Because that's what, and you can explain it to them just like I did. Say, if you have a room, and there's 1,000 staph people in it, and 2 Pseudomonas is standing over the corner, you're gonna get infected by staph, because it's the #1 bug on your skin. It also depends on the environment. If that person was swimming like in the sea and they have like a vibro type, it would be a different bug that would infect them. Or if they stepped on a rusty nail. It depends on what caused the trauma, the environment you're in. But most skin infections are staph. They are caused by the bug staph aureus. And you can just educate them and say, it probably is staph. Yes, sir.
Do infections with Pseudomonas have any different appearance? Like
In skin, it can, in like other areas, not veer off from your question, it can in toenails. Oddly enough, Pseudomonas in the toenails causes a very odd green, like putrid green color. In the skin, it has a really bad odor, I know that, because like in a diabetic ulcer, foot ulcer, it is a horrible smell compared to just that. Because Pseudomonas gives off a very, it's hard, it's almost a cross between like sweet and vomit. It's a very odd, it's a bad smell. Pseudomonas gives off a different, because it's a gas-producing organism. Yes, so Pseudomonas, it also can cause, you have something called necrotizing fasciitis, gas gangrene, it can cause different appearances, yes, but for the most part, just right off the bat visually, it is hard to say, well, this is caused by whatever. That's a great question. Usually your diabetics, if it's fit, you know Pseudomonas is probably one of the biggies causing it. It does have a weird scent. It's like BV. Once you smell bacterial vaginosis, you'll never forget it. It has the most distinct smell ever. Strep throat also has a really weird smell. Okay. Abby, how would you describe this?
Erythematous, pustulant, on the upper right shoulder of the patient's back. I would measure it, describe the size. Carbuncle,
But do we usually say diagnoses in a physical exam?
no.
Probably painful to touch, increased warmth. You could say unroofed, you could say ruptured, you could say purulent drainage present. Yes, there's many ways, yes, you could say that. Excellent question.
So instead of saying carbuncle, what would you say, a nodule? It's kind of big to be a nodule.
You could say mass. You're right, nodule, because that's where the whole morphology comes in, because in there, it gives you measurements of certain things, right? Like, less than this, it's a papule, greater than this. I usually like to use the word mass. That's like my go-to. Or lesion. We love the word lesion. That's kind of like your general. So 5 centimeter by 6 centimeter mass. Draining mass, purulent mass, fluctuant mass. Yeah, you can use that word. That's my go-to.
Would you guess the edges to be somewhat like indurated?
Say that again, I'm so sorry.
Like, could you describe the edges as like indurated?
Yes,
like
okay,
hard?
that's excellent. That is actually, because the thing about it is, not that you want to document defensively, but let's say you saw a patient who had an abscess that was starting to form. You saw them on Monday, it was indurated, there was nothing fluctuant. So you documented that, just 5 centimeters by 3 centimeter indurated mass. Then they went to the ER like 2 days later, or went to your partner 2 days later, and they had a huge fluctuant area. And your partner comes to you and goes, why didn't you drain them 2 days ago? That's highly irresponsible, yada, yada, yada. And you can say, look, bud, go read my note. They were not fluctuant at that point in time. So I didn't drain them because it would have been for naught. So you do. I'll actually comment on like 7 centimeters by 6 centimeters indurated area, center fluctuant area measuring 3 centimeters by 2 centimeters. You can even be that specific. Hell, you can do it by the erythema, how big the erythema is, how big the induration is, and how big the fluctuant area is. Sure you can, yeah. That's the beauty of derm, and that's where it actually is kind of annoying. Because you just want to slap something down. You want to say it's a red mass and it's draining. Move on. But you do need to be very descriptive in derm. You do. So that's a great question. You can because you'll have areas of erythema, or and we'll get to cellulitis in a minute, that will not be hard yet. It will not be indurated yet. So you'll have a big old ring of redness, and you touch the outer border. It's normal. It feels normal. It's soft. You move it a little bit, then start your induration. Then you move it a little bit, then it's like water blooming. You can comment on all of those areas, and it's actually the appropriate thing to do. Because erythema is important to comment on. Why? If they come back in 2 days.
Growth.
What?
Growth.
Growth. Is it freaking bigger? God dang, you're not getting better. That Bactrim pignon's really not doing the trick here. Great questions. I love that. It makes me pay attention. Okay, much like your folliculitis, this is just a visualization here. You're not doing any fancy stuff. But again, like most things I talked to you about today, if you want to go further, if you're sitting here like you're diabetic, or you're that lovely patient that gets an antibiotic every single month for your stinking cold, or you may want to do a culture and sensitivity of the wound if you really want to get back a bacteriogram. It's not wrong to do that. If you did it right off the bat, there's nothing wrong with that. No one would get onto you for that. You could, this is kind of going along with your EMR question earlier. Like, let's say you had an individual that you're like, you know, he's a diabetic, you really want to make sure you get this medication right. I do this all the time. I do in my practice. You can take a culture of it. It usually takes about 3 days to get your resistance and susceptibility report back. So you take a swab of the gunk, you go send it off, they plate it, and then they grow it out and they drop, I don't know how they do it, but they basically expose it to like 7 different antibiotics. Bactrim, Keflix, clindamycin, decloxacillin, whatever. After about 3 days, it kills off certain ones, and it won't kill off, the drugs won't kill off, so they'll send you this report. It has an R and S. Have you ever seen a susceptibility and resistance? Okay. It is your best friend in your clinic. Don't ever forget about it. It's awesome. So what I'll do is I'll see Joe Blow on Monday, take a swab. I know 3 days, but I don't want the dude to sit around and not be on anything. So I will actually start him on an antibiotic that day. And I'll tell him, I'll say, look, once this report comes back, probably going to have to stop that medicine and start a new one. And that would be an instance where I would feel totally comfortable just calling in a new antibiotic for them. Whoops, I put you on Bactrim. A bacteriogram came back, it's resistant. Sorry, I got to switch you to Keflix. You can do that. Anytime someone has what I would say systemic type symptoms, fever, chills, nausea, I just don't feel good, you can totally get a CBC on it. That's cool, you can do that. You will not most of the time. You won't. But you can. And I even wrote out for you what you would see. Obviously, you would see a leukocyte count. Treatment, again, you got to think of this on a spectrum. Not every Joe Blow that walks in there, you're going to throw clindamycin at them. This is just going to come in time with being an experienced provider, seeing enough infections and feeling comfortable not sending everybody out on antibiotics. You're going to want to do it. If it's mild, I would say like the gentleman above who just had the one single, it was an African American picture, not the neck one that had all the bad ones. I would consider that mild. If he's a healthy dude, his past medical history is not scary, he's not on any immunomodulators, he's cool, I feel comfortable doing some warm compresses, keep the area clean, put a little Neosporin on it, call me if it gets worse. You can do that. I put incision and drainage on there. We'll get to that in a little bit, but again, if you feel like you need to drain it, go for it. Most of them at a mild case, you will not. If it's more involved, or it's considered a complicated, and you can go look at the different factors that put your patient into that complicated category, you're going to want to start them on an antibiotic. It's somewhat the same that we've already discussed. You can do a Keflex, you can do the decloxacillin, clindamycin, Bactrim, there's a lot of different ones you can do. Again, I love Keflex. It's usually my first line that I do, that or Bactrim. I love Keflex. You don't get a lot of side effects? Yes, sir.
I just had a quick question.
Yes, of course.
Is there any place where you wouldn't want to drain it? Because I had one right here in my eye, and it was like protruding into my vision. It was like I see a round bump, like it progressively grew more and more, and he just stabbed like right into it. And I was a typical patient, like I Googled it, of course. Yeah. And then I found a couple places it was like placed in like major sensitive areas like the eyes or stuff like that. You shouldn't stab into it, but he did. And he gave me antibiotics and stuff. But is there
Can I erase
any?
this?
Yes.
Yeah.
Okay, two ways to go on your, God, yes, get it on there. Yes, I was on that phone call out in the hall. I'm just kidding, I'm not smart enough. God, I know, man, he does all his debriefings or teaches us too, and I sit there and I feel so good, like, man, I get this. And I get excited, like, I want to learn this, I want to be smart like this. But it's just something that if you put it down that day and don't pick it up until it's like all over again, I feel like an idiot. I'm just like, I'm so embarrassed. And he will call on us, like, Andy. And I'm like, I swear to God, I'll be like, I get a phone call. I love it. I'll be like, Mom, that piece of it's just hard stuff, but I swear, it really is, it can be important. I know, it's just one of those things, if we don't feel comfortable with something, we tend to shy away from it. But I want to be smart like that. I do. Okay, so to your question, there's actually kind of some guidelines when it comes to a person's face that I was taught, and I will not mess with it. And they call it the triangle. Like, so if you have a face, this is awesome. Yeah, look at that. Like this zone is what I was taught that you never touch as a PA, as anybody. If you were a family medicine doctor, if my husband was trying to get well, he'd actually do it. He would do all kinds of business in here. This is where I send people to plastics.
See, that's what it says.
Even if it's for draining, even if it's for some suturing. I will not, the first time I actually had a kid come in and I needed to do a lap repair over his eyebrow, well, I'm like, I'm amazing. I'll go in there and do it. I had just graduated and Dr. McNeil's like, come here. Don't ever do anything on someone's face in this zone, or face period. Because of, and why do you think that is? Why do you think it's the face? Yeah, people come back and be like, God dang it, you punched that needle in my nose and look at this ugly, yeah. So I get within the ER.
No, it's just in like a urgent care type.
Okay. ER they probably will, because you're in the ER, we gotta go for this, but actually they'll burn plastics down and do it right then and there. This is the safety, this is the zone you don't mess with. You can, for something as simple as what you have, if you're in a good area, like I was at the Health Science Center, I would just call plastics and be like, dude, I got this kid who has an abscess, or I got this kid who has a lac repair on his eye, I need a lac repair on the eyelid, can you take them? They know, they are like, absolutely, bring them over. You can do it, but that is like the area that we tend to tell people not to touch unless you're in plastics. Now going also with your thing, Travis, you do need to drain stuff in this area. Why is that? You gotta be careful, you can't just let orbital cellulitis, but it can eat in and cause to what?
CN6.
Like a cavernosus, it can like eat even further and cause major damage. So people are very, like, we gotta get this taken care of because it can eat through. That was a lot, sorry. But great. I would have probably drained it right there on you.
Yeah.
I would have probably, I'm not gonna lie, I probably would have done it, especially if he just used like an 18 gauge on you.
Yeah, I think that's what he did. Then he squeezed the crap out of it.
Yeah, I would have done that
That
also.
hurt. Yeah.
Okay. This is just a nice little picture of basically all three. You want to like use something to kind of compare the amount of tissue that's involved. So again, folliculitis, just that follicle. Furnicle, you can see those little WBC, those little dots. It's kind of moving out a little bit further. Only one follicle's involved, and then carbuncle's moving out even further. And essentially, how much area is involved is what you're going to see on the other end or on the surface. That's what you're going to see, right? Don't worry about the medication things on the bottom. That's not what that slide's about at all. I just wanted to give you a picture. Does anybody have any questions about those three things? I just really want to make sure you get this. Pretty basic. Just another picture. Okay, cellulitis. You're going to get tons of cellulitis all the time. It took me a long time to think about it like this. A long time, I'm really impressed. Every time you think, oh, cellulitis, it's abscess, it's abscess. It's not. All cellulitis is infection of that skin that's red, hot, painful. That is what cellulitis is. Abscess is below the surface. You got a nice pus ball forming. So when you go to code for your patient, you need to be specific. Don't say cellulitis, and I was actually gonna add in the ICD-10 codes for all these, but I thought it would be just overwhelming. There's actually just cellulitis. There's cellulitis with abscess.